Hi, dear ladies and gentlemen. I'm Dr. Ayten Saraçoğlu from Marmara Medical School, Istanbul, Turkey. It's a great honor to talk on this important topic. I would like to thank Scientific Committee for their kind invitation and their valuable efforts on these hard days. And in impairment in microcirculation after traumatic shock associated with greater risk of multi-organ failure, delayed mortality, morbidity, and prolonged stay in ICU. And therefore, we will deeply focus this problem today. And I have to say, I have no conflict of interest with any company. This is a number of publications on microcirculation in recent years with growing body of data. And this is a Microsoft study. This is a multi-center observational point prevalence study, including 36 ICU beds, ICUs worldwide, and with 500 patients. They found with the use of SDF imaging, abnormal microvascular flow index nearly 17% in ICU patients, and also it's related with a higher mortality. Today, my talk will be following definition and history of microcirculation, pathophysiology of traumatic microcirculation, monitoring the microcirculation, and lastly, I will talk on protection and treatment of microcirculation. And let's talk about a network consisting of arterioles, capillaries, and venous lower than 100 micrometer diameter. If you connect all microvessels in your body end to end, you will find long enough vessels line wrap entire world nearly 2.5 times. It's really amazing, greatest, largest endothelial surface in the body, and also key location for cellular oxygen and substrate transfer, and a critical role in modulating vascular tone, and also a critical site for flow limitations during traumatic shock. And adequate microcirculation relies on the function of different components of microcirculation, such as convective and diffusive determinants, and capillary resistance, rheological factors, and also muscles, vascular muscles. And when we look at the history of microcirculation, first time Leonardo da Vinci explained small microvessels, and he termed as capillaries. After that, Dr. Cannon first described hemodynamic coherence and microcirculatory dysfunction. Till the end of Second World War, the use of blood and plasma for trauma was a standard practice. And Dr. Shires in 1960s explained reappraisal of nature of the volume losses. And in Second World War, in Vietnam War, the fluid-based resuscitation was the really important topic, and they was aware of ARDS. And Dr. Gruner et al. In late 1990s, first time discovered video microscopes with imaging guided microcirculatory treatment. If circulation unable to meet tissues demand, oxygen demand, and that results in shock. And after a stage, microcirculatory failure stage, it will be irreversible, and patient will not respond to resuscitative efforts even initial damage have been corrected. Therefore, we should treat microcirculation as soon as possible. And alterations of microcirculation in trauma caused by hypoperfusion, inflammatory response, and subsequent reperfusion injury, and they will result in decreased functional capillary density and diffusion distance, decreased oxygen diffusion, intravascular thrombosis, and increased vascular resistance. And this is a key issue, is this relationship or degree between macrocirculation and microcirculation, and between this is if it's intact, optimization of microcirculation may improve tissue perfusion. And all this causes impairment of mitochondrial respiration, reduced ATP production, and finally causes cell injury and apoptosis. And all monitorization are used to optimize patient hemodynamics, but the ongoing clinical dilemma is persistent tissue hypoxemia and reduced oxygen extraction despite recovery of systemic oxygen delivery variables, because they are affected many factors, and also their predictability is very low. So we are still blind the quality of actual tissue perfusion, and with handheld video microscopes, they are non-invasive window to evaluate microcirculation in shock states. Basically, they have LED camera in the center optics and takes image via green light absorbed by hemoglobin in the vessels. But they also have many limitations. And this nice study revealed sublingual microcirculation was impaired for nearly 72 hours despite restoration of macrocirculatory variables. And also the initial proportion of perfused vessel density associated with SOFA score on day 4. And this is microdavin study, including 19 beds ICU from Italian teaching hospital. Microvascular flow index, low microvascular flow index related with decreased survival. And according to this microshock study, patients with a greater decrease of microcirculatory impairment exhibit higher lactate concentrations and also increased crystalloid resuscitation, required crystalloid resuscitation. And they concluded that microcirculatory parameters are better prognostic indicators development of multi-organ failure. And this is the second consensus of assessment on microcirculation. They emphasize microcirculatory measurements should be integrated with macrocirculatory measurements to provide optimal patient hemodynamic picture. And what is the best, which treatments might restore microcirculation? And I think this is not enough pressure or flow-based resuscitation, because we have still a matter of the debate because of heterogeneous data and with high risk of bias. But maybe we can see the tissues, microcirculatory oxygen tension, capillary vessels density, and then we can treat the patient. And we know increasing cardiac output, early fluid resuscitation, and also some vasoconstrictor or vasodilator drugs and anti-inflammatory cytoprotective drugs, and even anticoagulants and anesthetics have been used to improve microcirculation. But all maneuvers should target a reopen of capillary network and also decreased heterogeneity. First tool, fluids. And all type fluid normalize intravascular and cardiac feeling to greater or lesser extent to type of fluid. But what is the ideal fluid? On the one hand, a fluid treatment can increase convection in the blood and increasing proportion of the perfused vessel density. But in the other side, fluid can cause tissue edema and injury to lung endothelium and decreased diffusion distance. And therefore, ideal fluid should have restoring properties of endothelium and inflammation and improving microcirculatory parameters. And this is a nice study review article, and they found this all of properties required to increase microcirculation, and they also can reduce inflammation. And this is the nice Cochrane review, including 69 studies and greater than 30,000 patients, and probably all correlates has little or no difference on mortality, and they increase also blood transfusion rate and renal replacement treatment. And this study and is find interesting finding, and some patients has needs maybe 500 milliliters fluid, and others patient need 5 liters to have same macrovascular indices. Therefore, we should treat patients according to microcirculatory indices. And this is a nice study published in Anesthesiology. Saline only improved macrocirculation, but not microcirculation. And this all fluid resuscitation was found to improve microcirculation, but they also increase colloids, increased renal reactive oxygen species production. What about the blood transfusion? And blood transfusion also RBC plays oxygen sensor and also oxygen carrier in the blood and increased convection and also decreased diffusion distance in the blood. But sometimes they have some side effects, and also transfused RBC shortly after hemolyzed in the blood, and it causes free hemoglobin, increased free hemoglobin level, and this causes vasoconstriction in the body. And also they have some adhesion and close the capillary features, and also traumatic shock damage RBCs deformability and also cellular damage. And in the study they found full blood transfusion decreased the patient's microvascular indices because of RBC adhesion in the capillaries. And according to this study, they compare saline and blood products. Saline treatment decreased the perfused vessel density, and they cannot improve microcirculation with the blood transfusion in these trials. And they was aware of sometimes transfusion is not necessarily required, and if necessary we should transfuse the patient because of the side effects of transfusion. And this study also supported this value. And according to this good scoping review, they found in some population blood transfusion is acceptable, for example hemorrhagic shock, but some patients, most patients, septic patients, cannot improve their microcirculation. We cannot improve their microcirculation with blood transfusion. And what about the hemoglobin based oxygen carriers? They found they increased the percent of survival and also tissue oxygen tension. According to this study, sanguinate increased the perfused vessel density and longer animal survival. And what about the vasopressor, vasodilator? Excessive vasopressor decreased the diffusion distance, and norepinephrine decreased significantly all microvascular variables, and sodium nitroprusside increased the microvascular perfusion. And what about the oxygenation? They found normobaric hyperoxia essential for our patients, because hyperbaric hyperoxia decrease all microvascular indices and also increase the heterogeneity of the blood. And then they search about which concentration of oxygen is required to optimize patient mucosal oxygenation. They found a normobaric normoxic resuscitation is the best, because not different, at least had same microvascular perfused vessel density found when they compare with hyperoxemic trial. And treatment should be based what's the wrong. So if signs of hypoperfusion in the presence of normalized macrocirculatory variables require possibly vasodilator agents. If patient has hypovolemic microcirculation, and then patient requires RBC transfusion, hemoglobin based oxygen carrier and volume replacement. If patient has heterogeneous flow indicating some inflammation or endothelial dysfunction, we can use anti-inflammatory cytoprotective strategies. And finally, we should treat patient microcirculation look good, but it's not important. We should target microcirculatory and mitochondrial treatment. And also, if we cannot monitorize, we cannot treat our patients, and we need microcirculatory flow meters to treat our patients effectively. And we need also further large-scale clinical studies. And then we should treat all three compartments, macrovascular, microvascular, and cellular compartment. And we have no magic bullet, and please open ProShite, and also don't overshoot our patients. And so adequate microcirculatory perfusion should be a potential endpoint for our treatment. Thank you very much for your attention and your patience.